Thanks very much. Good morning, everyone. So, as Kelly said, I'm Jonathan Squires. I'm one of the neurologists out at the UBC Movement Disorder Clinic. And today we're here for the first of a four-part series about basically kind of an introduction to Parkinson's disease. My job today is to tell you sort of what is Parkinson's disease, what causes it, how we diagnose it, and some of the symptoms. And then over the next few weeks, my colleagues are going to go through a number of other topics, including how it's treated and some tips on living well with Parkinson's disease. So I'm going to take you through the first four parts of this today. A bit of a whirlwind tour through Parkinson's disease. So we've known about Parkinson's for a long time. So this is the gentleman, James Parkinson, who first described it and who it's named after. So he published this paper back in 1817. So we've known about this disease for about 200 years, a little over 200 years. So what is it? Parkinson's is a neurodegenerative disease. So that's an umbrella group of disorders that include things like Huntington disease, Alzheimer's disease, ALS, for example, where certain populations of neurons or brain cells are slowly dying away. Now, in Parkinson's disease, one of the big populations of brain cell that we talk about are the brain cells that make dopamine, which is a neurotransmitter that's important for movement as well as a number of other functions. These aren't the only brain cells that are dying away, but these are the ones that we tend to talk about the most. All neurodegenerative diseases, regardless of what it is, are characterized by buildup of an abnormal protein inside the brain cells. And we think that those abnormal proteins, something about them, are toxic and they cause the brain cells to die away. So in Parkinson's disease, the abnormal protein is called alpha-synuclein. And if you look at the brains of someone with Parkinson's disease under the microscope, the clumps of alpha-synuclein that you see have been called a Lewy body, after Dr. Lewy, who first described them. So I mentioned dopamine. So it's a neurotransmitter, so a chemical messenger that brain cells use to talk to each other. So it's important for control of movement, but also mood and many other functions, which are important when we come to talk about the symptoms of Parkinson's disease in a few moments. So now we have a bit of an idea of what it is, what causes Parkinson's. This is the million-dollar question. And what it comes down to is that for most people, we really don't know, unfortunately, what causes Parkinson's disease. Some cases are genetic, maybe 10, 15%. These people who have genetic forms of Parkinson's often, but not always, have young onset Parkinson's disease, so before the age of 50. And usually there's a strong family history. Not always. Some of the genetic causes are what are called recessive disorders, where you have to have one copy of the abnormal gene from each parent. And in recessive conditions, there often isn't a family history. Certain ethnic groups are more likely to have a genetic cause of their Parkinson's disease. For example, people of Ashkenazi Jewish ancestry are more likely to have genetic cause. And so certain other groups are kind of enriched with certain mutations. So other than the folks who have a genetic cause of Parkinson's, like I said, we don't really know what causes it, but there are a number of well-established risk factors for developing Parkinson's disease. The biggest risk factor is age. So about 1% of people over the age of 65 will have Parkinson's disease, and 3% of people over the age of 80 have Parkinson's disease. And the incidence, the rate of having Parkinson's climbs steadily with age. Men are more likely to get Parkinson's than women. So it's about two-thirds of people with Parkinson's are men. Don't really know why. People wonder whether estrogen, for example, may be protective for women, but it's not really clear why that is. Having a history of recurrent head injuries, so concussions, especially if there's altered level of consciousness, is a risk factor. So that's relevant, especially for people being professional athletes, for example. Living in the countryside, people who live in the country are at higher risk of getting Parkinson's than people who live in the city. And that may just be a marker for exposure to certain chemicals. So we worry about certain pesticides may increase the risk of Parkinson's disease. Heavy metals in the groundwater, if you drink from a well. We don't really know, but there's some environmental exposure that folks who live in rural areas are more prone to be exposed to. And then family history. So even in the absence of the gene, so these are statistics around people who do not have a genetic cause of Parkinson's disease. So if you have an affected first degree relative, which means a parent, sibling, child, I suppose, who has Parkinson's disease, your risk of getting Parkinson's is about 2 to 3 times the baseline population risk. That sounds alarming, but the likelihood that any given individual is going to get Parkinson's disease in their lifetime is less than 1%. So if you double or triple that, you're still probably looking at around 1% or less risk of getting Parkinson's. And this presumably reflects that there's some kind of genetic predisposition or genetic risk that we haven't fully teased out yet, or the similar environmental exposures or some combination of the two that accounts for this increased risk. So at the end of the day, when we don't really know what causes something, we tend to wave our hands a little bit and conclude that there's probably some combination of genetic predisposition, environmental exposure, and a healthy dose of bad luck that causes Parkinson's for most people. But it's definitely an important question, and there's lots of research going on trying to identify the cause of Parkinson's. So how common is Parkinson's? So Parkinson's is the second most common brain condition after Alzheimer's disease and is actually the fastest growing neurological disease in the world. So we project the number of people living with Parkinson's disease is going to double in the next 10 years. Currently in British Columbia, it's estimated that just shy of 18,000 people are living with Parkinson's disease. 3 or 4 years ago, that number was about 15,000 people. So you can see that the numbers are starting to increase. And then there's at least 100,000 people with Parkinson's in Canada, based on some older estimates. And you can see below a graph with the age breakdown. And you can see that it does increase with age, but there's a significant number of people, younger people living with Parkinson's as well. In fact, probably 1 in 7 people living with Parkinson's will have their symptoms start before they turn 50. Okay, so how do we diagnose Parkinson's disease? So it turns out Parkinson's disease is a clinical diagnosis. We'll come back to this. So we diagnose it based on the story that you tell, the symptoms that you've been experiencing, along with the physical exam. So the first step that we do is to determine whether you have any signs of Parkinsonism. So Parkinsonism is a descriptive term, which means some combination of slowness of movement, which is also called bradykinesia, which is a Greek word, increased muscle tone or rigidity. So we move your arms and legs around and we feel resistance to passive movement, and a resting tremor. So the tremor that people with Parkinson's get typically is when you're completely relaxed, your arms are resting on a table or in an armrest of a couch or something, and it shakes. And then when you move your arm, the tremor goes away. That's the kind of tremor that we see with Parkinson's disease for most people. So once we determine whether you have Parkinsonism, the next job is determining what is the cause of the Parkinsonism. There are many things that cause Parkinsonism. Parkinson's disease is the most common by a long way, but there are still some other things that mimic it. So what we do is we look for other features that someone may have that we don't expect to see in someone who has Parkinson's disease. That raises a bit of an alarm flag. Unfortunately, most of the things that look like Parkinson's but aren't are a little less pleasant than Parkinson's disease even. So we always, in some morbid way, hope that people have Parkinson's disease if they come to us with compatible symptoms. There are certain medications that can cause similar symptoms as well that are reversible, but that's usually fairly evident. So I mentioned it's a clinical diagnosis. So the only confirmatory test we have today is an autopsy, which in my experience has not been a popular option. So brain scans that we have, like MRI and CT scan, generally are normal. So if we do a brain scan, it's to exclude, basically, we don't think you have Parkinson's and we're looking for signs of something else. You may see some atrophy or shrinkage of the brain in someone with Parkinson's, which is nonspecific. Anyone over the age of about 25, our brains have started to slowly shrink. So nothing specific to show us. And then there are other fancier tests like PET scans, a DAT scan, which is a nuclear medicine study that can kind of give you supportive evidence, but have a lot of false positives and false negatives. So most of the tests that we have that are helpful are actually no better than being assessed by a neurologist who has some experience with Parkinson's disease, as it turns out. So I not infrequently will see somebody who came in and said, oh, the doctor just made me do this and this and told me I had Parkinson's disease, that quack. And I have to sort of explain, like, yes, in 2025, unfortunately, that is still, for the most part, how Parkinson's is diagnosed. Seems a bit wild when you think about it. There is, you may have read about a diagnostic test called an alpha-synuclein seeding assay that is in development right now, which is very promising. It is done in spinal fluid, so you have to have a spinal tap, a sample of fluid withdrawn, but that is about 90% accurate in making a diagnosis of Parkinson's. Still not 100, but much better. So that's not quite ready for clinical use, and they're trying to make it work in blood, but that will be coming. So stay tuned. So I mentioned that there are things that look like Parkinson's that aren't. And as a specialist dealing with Parkinson's, when people are coming to see me, especially in the first few years of the disease, we're always on the lookout for any signs of anything that isn't Parkinson's disease. So the most common things that we would be considering would be medication-induced Parkinsonism. This is almost always from antipsychotic medications, but there are a few other things that can, certain anti-seizure medications, certain anti-nausea medications, especially a drug called Maxaran or metoclopramide, and one or two others. But this is not that common and often fairly evident. Structural lesions in the brain, quite rare, but if you have some kind of lesion, a stroke, a little tiny hemorrhage, a tumor in just the right spot, it could cause symptoms that look like Parkinson's, though it shouldn't progress over time unless it's something that's growing like a tumor. More commonly, what we're looking at is a group of other neurodegenerative disorders, rare things like progressive supranuclear palsy, multiple system atrophy, that are much less common, but tend to be more severe. Unfortunately, they progress more quickly and don't respond as well to treatment. So, Parkinson's disease is a clinical diagnosis. Diagnosis is made by human beings who are fallible, unfortunately. And we know that we get the diagnosis right only about 70 to 80% of the time in the early stages of Parkinson's disease. And most of the things that we misdiagnose it at are one of these other things, particularly this group of the neurodegenerative disorders. So these are the PD mimics. So like I said, we're always on the lookout for things. The mimics of Parkinson's disease can present exactly like Parkinson's disease. The best doctor in the world wouldn't be able to tell them apart in the early days. But over time, people tend to start to diverge and go down slightly different pathways. Weird symptoms come up, but the progression's not quite right. And so we try to pay attention to this, and sometimes we may revise the diagnosis over time. Typically, if you've had Parkinson's more than 5 or 6 years, you're pretty on more solid ground with the diagnosis, but in the early days, it can be hard to tell. This is why diagnostic tests like this synuclein seeding assay are very important and will help coming up with treatments for the disease itself develop a little more quickly. Obviously, if you're developing a drug that treats Parkinson's disease, you want to give it to people as soon as possible. So we need a diagnostic test that can tell these diseases apart in the earliest days, so that we're not testing it on people who don't have Parkinson's, because you may miss the signal that it works if you include too many people who don't have Parkinson's. If that makes sense. One question that I often get multiple times a day is, what does the future look like? How will this condition progress? What will things be like in 5 years or 10 years from now? This is a difficult thing, because the answer is that progression is highly variable between individuals. So the best predictor of your future is going to be your past. So Parkinson's disease, even in people with rapidly progressive Parkinson's disease, still progress over years, not over days and months. However, there's variability in the rate, but your particular individual rate of progression will not change over time. So if you're going very slowly like this, you stay like this. If you're going very quickly like this, unfortunately, That's how things are going to progress. But it is very difficult to predict, and that uncertainty around how things are going to be really weighs heavily on people. If I could say, oh, well, 8 years from now, you're going to be in a wheelchair, well, that sucks, but you can plan for that. Whereas if you're left with this kind of amorphous list of things that could happen, I think people really struggle with that. In general, women tend to progress more slowly than men. People who have younger onset of Parkinson's tend to progress more slowly as well. And people with tremor-dominant Parkinson's disease typically progress more slowly as well. So if you're a younger woman with a lot of tremor, that's the kind of the best prognostic picture you can have. But having said that, a lot of men progress really slowly as well. So a lot of variability. Now, one thing that's important to keep in mind is that if there's any sort of change in the pattern, like you wake up and feel like, oh, hey, I feel like I've progressed 5 years overnight, that's not Parkinson's disease. What that is a sign that something else is wrong. So if someone with Parkinson's has anything else going on, like an infection, a lot of stress, you haven't slept in 4 days, some other medical thing, electrolytes aren't good, kidneys have packed it in, anything like that, that will cause a significant increase in symptoms. And so if someone calls our office and says, oh, hey, I think something's really wrong, my medication's not working anymore, then we always send people to see their family doctor first to get an infectious workup, other medical workup to make sure there's not some other problem going on. And almost always there is. Most common thing would actually be a bladder infection. And people with Parkinson's disease may not have any symptom of an infection other than their Parkinson's getting worse. Sounds a bit funny, but if you call your doctor and they say, go make sure you don't have an infection, that's why. So moving on to symptoms now. Symptoms like progression, highly variable from one person to the next. If you read about Parkinson's, there's a list of symptoms basically as long as you are that you could get. Nobody gets all of them. Nobody's that unlucky. But again, one of the problems is nobody can predict which ones you will have. So that can be a bit hard as well. Symptom-wise, we tend to break symptoms down into premotor, motor, and non-motor symptoms. So we'll move through those in turn, starting with the premotor symptoms. So these are things that can start years before a tremor or before changes in walking, that sort of thing. Sometimes 20 years or more before these other things start, but we recognize them as the very first symptoms of Parkinson's. So one of them is losing your sense of smell. So that can happen 20 years or more before anything else happens. It's a bit non-specific. People with COVID lose their sense of smell, etc. Lots of other things can, but many people with Parkinson's problem. Constipation can also start decades before Parkinson's. They have found Parkinson's pathology in the nerve cells in the gut of healthy people who went for colonoscopy, for example, who then some number of years later went on to have signs of Parkinson's disease. There's a funny condition called REM sleep behavior disorder, where people start to act out their dreams, which again can start decades before Parkinson's, very, very strongly associated with Parkinson's disease. So if you're a young person with REM sleep behavior disorder, there's a greater than 90% chance over the next 15 years or so that you'll go on to develop Parkinson's disease or one of the mimics. So with this condition, people will start to scream in their sleep, kick, punch, thrash around. Talking is not so specific. Lots of people talk in their sleep, various reasons, not always REM sleep behavior disorder, but acting out the dreams. And then changes in mood. So people who've never had issues with depression or anxiety in their life can sometimes develop those problems a few years before other things start. And in that case, we consider that to be an early sign of Parkinson's as well. Now, moving on to the motor symptoms. So the hallmark features of Parkinson's are tremor, which again, for most people is this resting tremor that goes away or lessens when you move your hands. Rigidity. So this isn't always that, a feeling of stiffness or anything. It's really more when we check passively that there's a resistance to the range of motion. This can be a bit painful. Things are tight. And also, I think sometimes people perceive rigidity and the next symptom, bradykinesia, together as a sense of weakness because your muscles are stiff, so you have to exert more force to do things you want to do, and the brain perceives that as a weak feeling, even though when we test your strength, things are pretty good. Now, bradykinesia is actually the hallmark feature of Parkinson's disease. It's not tremor, it's actually the slowness of movement, which, like I said before, is an old Greek word meaning slow movement. So if you don't have bradykinesia, you do not have Parkinson's disease. It is the one core symptom that is required. Now, people with Parkinson's basically have trouble maintaining movements. So that's why we make you do stupid things like this, because for someone with Parkinson's disease, trying to do a repetitive movement like this, it will slow down and get smaller. And that manifests in a lot of ways. So people tend to speak softly. The face becomes less animated, so the so-called Parkinson's mask. People walk more slowly and take smaller steps. The handwriting becomes smaller as you go, and the fine motor things become clumsy. So it's harder to do things like doing up small buttons, tying shoes, cutting up food, brushing teeth, that sort of thing. Anything that requires those repetitive movements becomes more challenging. So daily activities take longer, etc. And then postural instability. So people with Parkinson's generally will develop trouble with balance, but this is a late problem. And that's why if you've been to a neurologist and they do that thing where they stand behind you and push you backwards, that's what we're looking for, is postural instability. So usually we have the reflex where if you're starting to fall, you'll take a step out to catch yourself. People with more advanced Parkinson's can lose that reflex. And so if you start to go, you just kind of go. So that's why we're testing, looking for safety concerns. So those are the motor symptoms. There's a much longer list of non-motor symptoms. So we won't have time today to go through all of them in detail. And if you ask people with Parkinson's disease what really impacts their quality of life, as the disease progresses, people tend to have more and more of the non-motor symptoms, and they are the things that are really starting to be the biggest drivers of impaired quality of life. So there's several categories of changes that we'll walk through. Some of them are listed here. So mood changes are very common. Depending on what study you look at, it says here 50% will notice changes to mood. Some studies show that it's in excess of 90% of people. So this can be depression, anxiety, irritability. And of course, you might think, well, of course I'm depressed. I have Parkinson's disease. You wouldn't be depressed. But they've compared people with Parkinson's disease to things that are equally disabling, like bad rheumatoid arthritis, for example, where you can't use your hands to do much. And people with Parkinson's are much more likely to suffer from depression. And, it makes a bit of sense. Dopamine is in addition to helping movement, is also a good mood chemical. So if your dopamine levels are low, that will play in. And also other neurotransmitters that are important for mood, like serotonin and norepinephrine, those levels are also low in people with Parkinson's. Interestingly, people's loved ones often think people with Parkinson's are depressed because of the lack of facial expression. However, that's just a manifestation of bradykinesia, but depression can be overlooked, often underreported. So I try to ask about it every time I see somebody. People with mood changes related to Parkinson's, it's treated just like anybody else who doesn't have Parkinson's. So talk therapy, Parkinson's Society offers free short-term counseling for people, which is great. Antidepressant medications can help with both depression and anxiety. A number of things can help. When things get really severe, we usually refer people to psychiatry to help manage these things. So other psychiatric conditions. So apathy is very common with Parkinson's. So apathy is kind of a lack of motivation, just not interested in doing anything. My husband just sits in front of the television all day and won't do anything, that kind of thing. Usually that comes up later in the course of the disease, but could happen anytime. Apathy is something that we often associate with depression as well, but in people with Parkinson's, you can have apathy without any issues with mood at all. And this symptom, unfortunately, is one that doesn't respond that well to treatment. Generally, people's loved ones are generally bothered by it, though the apathetic individual, generally not. But it can be a little tricky one. Sometimes having a structured day, scheduling in things like exercise classes or social gatherings. Some people find that a bit helpful. Hallucinations can occur, usually later in the disease. They're usually visual. They can start with the sense that things are kind of flitting by in your peripheral vision, or misinterpreting things, like there's a sweater on the chair in the corner, and in the dark, your brain thinks that there's a cat lying there. And they progress along to, seeing people in the house, insects, that sort of thing. And can be disturbing. Again, these usually happen late in the disease. Sleep disturbances are extremely common with Parkinson's disease, and one of the bigger things that people struggle with. There are many ways in which Parkinson's can affect sleep. Now, I think the most common reason people with Parkinson's can't sleep is the same reason that most common reason in the general population, which is not being able to turn your brain off and just racing thoughts. So if that's the case for you, then the treatment for that is the same as it would be for anybody, which is kind of sleep hygiene and cognitive behavior therapy. But there are some other features unique to Parkinson's disease. So the circadian rhythm, which is the body clock, is dysregulated. So melatonin, which is a hormone that makes us sleepy, the levels of that are low as well. There are some other changes that influence the sleep-wake cycle. People with Parkinson's are more likely to have other conditions like restless leg syndrome, obstructive sleep apnea that can interfere with sleep. So people with slightly more advanced Parkinson's, their medications may wear off in the night, and they start to have a tremor, or their legs will cramp, and that can wake them up through the night. Getting up to use the bathroom, and that happens to all of us as we get a bit older, but more so with Parkinson's disease. So there are many things that can interfere with sleep. And when we see someone complaining of a sleep problem, we try to figure out, okay, well, what is it that's interfering with sleep, and what of those things can we do something about? Fatigue, very common, and can be unrelated to the quality of the sleep. So fatigue can just be a symptom of Parkinson's disease. Sleeping great, everything else is good, but still this really bothersome fatigue. And there are things you can do to help manage that a little bit, though fatigue can be a little bit tricky as well. And like I said, REM sleep behavior disorder can be disruptive to sleep, although often more for the person sharing the bed with the person with REM sleep behavior disorder. But it still can disrupt your sleep. So moving along, there's a whole category of sort of what we call autonomic symptoms. So the autonomic nervous system is the bit that control the sort of housekeeping functions of the body. So heart rate, blood pressure, digestion, bladder function, bowel function, that sort of thing. So quite a number of different things can happen from an autonomic perspective. Constipation, we mentioned, is very common. It's important to manage constipation. I'm sure my colleague will talk about this, I'm sure, but if you're constipated, it's harder to absorb the Parkinson's medications, so they won't be working as well for you. So it's really important to stay ahead of the constipation. Bladder dysfunction is very common, usually manifesting as having to go more often and urgently. Blood pressure regulation is affected as well. Mainly when you stand up, the blood pressure will drop. That can happen to anybody, of course. If you're a bit dehydrated, especially, it will happen a bit more so with Parkinson's. And unfortunately, pretty well all of the medications we use to treat the symptoms of Parkinson's can make this problem a bit worse. So again, something that we monitor for. Cold hands and feet, very common. Again, changes in blood circulation. It never gets to a dangerous point where you're going to like lose circulation or anything like that, but kind of a nuisance, bothersome problem. And then sexual dysfunction is very common in both men and women with Parkinson's. I was scrolling through the Parkinson's BC website the other day and see that they have an upcoming webinar on this as well. So if this is something you're struggling with, I'd encourage you to attend that, ask your doctor. But erectile dysfunction, very common. Women also have changes in sexual function. Psychological aspects of Parkinson's disease affect sexual function. So definitely something to bear in mind and treatable. So if you're struggling with this, talk to your doctor. And then other symptoms. So pain is very common. Pain can be a little bit of a tricky one. So Parkinson's disease can cause pain. So the so-called central pain syndrome, which is pain that comes from your brain. So the pain centers of the brain can become hypersensitized in Parkinson's disease. So you can have a sense of pain even though there's nothing painful happening to your body. That kind of pain gets better with Parkinson's medication. Like it will go away with Parkinson's medication. So that's the pattern where your pills wear off and you have this pain and you take your next dose, the pain goes away. That's the central pain of Parkinson's disease. Pain that doesn't change with the Parkinson's medication is more likely to be musculoskeletal, arthritis, tendonitis, bursitis, that sort of thing. And that pain is treated just like that pain would be for anybody else. And we usually defer that to people's family physicians because we don't have a lot of experience with managing it as neurologists, unfortunately. Cognitive changes will eventually occur in most people. So if you follow people with Parkinson's for 20 years, 80% of people will have some degree of dementia, which is one of the more dreaded symptoms of Parkinson's disease. It's not inevitable and less common with people with younger onset, but that is something that we monitor for as well. So that's actually everything that I have in terms of the cause, a little bit of an overview of the symptoms. These are my dogs. If you've heard any barking in the background, this was who was making the noise.